once again, I'm Pete Cohn, and we're going to continue sort of the theme of trauma that we've been on for the last couple talks and move down to the thoracolumbar spine today. So this is a brief outline. We're going to try to focus mainly on the last two topics here, and I'll try to breeze through some of this earlier stuff. But basically, thoracolumbar spine injuries are common. About 4%, sometimes up to 6% of all trauma patients coming through the level 1 trauma center have thoracolumbar spine injuries, and about 90% of all spine fractures occur in the thoracolumbar region. Most commonly, these fractures occur between T11 and L1 at the thoracolumbar junction, presumably because this is the area of transition, acute transition and rigidity from the thoracic spine to the relatively more mobile lumbar spine. And these injuries are associated with a 15 to 20% rate of neurologic deficits. Some brief anatomy points. Thoracic spine has kyphosis. The thoracolumbar junction is relatively straight, and the lumbar spine is orthotic. There's also a change in the facet orientation between the thoracic spine, where the facets are more coronally oriented, and the lumbar spine are more sagittally oriented. Oops. So this is just to really just go over the ligamentous structures, but also describe the sort of column model of spine. I'll add this box right here for Dr. Gelb. So the spine can really be divided into two columns, anterior and posterior, and there's also really two tension bands that hold everything in place. So anteriorly, you have the ALL, or the anterior longitudinal ligament, which is your anterior tension band and your primary restraint, along with your posterior osseous structures to restraint to hyperextension. And posteriorly, you have your posterior ligamentous complex, comprised of supraspinous ligament, interspinous ligament, ligaments and flavum, and facet joints, and that gives you a tension band restraint to flexion. And these two columns are really what we're going to be talking about when we get into classifications between the anterior column and posterior column. So we'll go into basically the initial evaluation. I'm not going to go into the details of history and physical today. I think we all know the importance of that. But we'll jump right into who should get imaging, which trauma patients or patients coming into the emergency department should get imaging of their thoracolumbar spine. So this was a study, observational study perspective, looking at over 2,000 trauma patients who came into 4 different institutions. They found 152 thoracolumbar spine fractures, and they looked back and they came up with 6 criteria that they hypothesized would, if any one of them were present, that they would pick up all the thoracospine fractures. And so these were the criteria they selected, and it's similar to the Canadian criteria for the cervical spine, but really any pain or tenderness in the thoracolumbar area, and really any sort of change in level of consciousness, whether that's due to intoxication or the injury, any abnormal neurologic examination findings, and any distracting painful injury. What they found was if you use these criteria, you can find 100% of thoracolumbar spine fractures, which was really their goal. And they had 100%, negative predictive value. So if you can say that none of these factors are present, then you can probably safely avoid imaging patients. However, if any of these are present, it's probably worth at least getting X-ray imaging as some sort of screening tool. But then that gets into what is the best imaging modality for screening for thoracolumbar spine injuries. X-ray is obviously cheaper and less radiation, but in some institutions may actually take more time than a CT scan, especially for trauma patients who are getting CT scans anyway. And so this was a study looking at about 200 patients who came in to trauma centers, and they were determined to be high risk for injury based on either clinical findings or a high energy mechanism with altered mental status. And they compared essentially X-ray of imaging of the thoracolumbar spine to CT imaging, usually from a chest, abdomen, pelvis scan. And sort of predictably, what they found was that the CT was much more sensitive in picking up thoracolumbar spine fractures, and also much more specific. Interestingly, though, the fractures that the CT was picking up that X-ray were not were almost all transverse process fractures or spinous process fractures. And really anything that the CT found, X-ray also found, but no unstable fractures were missed by the X-ray technique in this study. So even though the sensitivity and specificity were low for X-ray, most of the things that were missed were relatively inconsequential, at least in this study. This was another study looking at using the reformatted visceral helical CT, which is a different type of CT scan. And again, they were comparing this to X-ray. And again, they found that that the CT was very sensitive and specific for finding injuries. But in this study, they actually found that the X-rays did miss a couple of unstable injuries. There was one thoracic T6 flexion distraction injury that was missed, and one unstable L3 burst fracture that was missed as well. So this study seems to suggest that the CT is really a more sensitive, specific screening tool for thoracolumbar spine fractures. And then I just included this really quickly. This was a study just comparing CTs that were formatted for chest, abdomen, pelvis to see if there was any difference in the screening use of a CT chest, abdomen, pelvis scan versus the specific thoracic and lumbar reformats. This was done at an institution, I think it was at Dartmouth, where they routinely get thoracic and lumbar reformat for all their CT scans, but they went back and they had a radiologist look at all the chest, abdomen, and pelvis reformats to see if they could find all the fractures with that reformat. And what they found was that essentially they found all the injuries on a chest, abdomen, and pelvis CT. The only two that were missed were again TP fractures in patients who had multiple other fractures. And in those cases, those other fractures were detected by the radiologist. And so really, this is just to point out that if a patient comes into is transferred in and they have a chest, abdomen, pelvis CT, you probably don't need to reorder a CT to get thoracic and lumbar reformats just to rule out injury. So now that we've found, a fracture, we've seen our patient, we've gotten our imaging, we've determined that there is an injury. The next step, of course, is to determine what kind of injury this is, what is the severity, what's the best way to communicate about this injury, and then what do we do about this injury. So there's a couple classification systems in place, and we'll talk about really two of them today, which are really probably the ones we use the most at our institution. The first is the TLEX Score, which is really a classification that is geared towards guiding management. And this is a classification system that's based off of really three areas: the morphology of the fracture, the neurologic status of the patient, and the integrity of the posterior ligamentous complex. So it's a point system classification where point values are assigned to the morphology. So with increasing severity, you get more points for neurologic involvement. With increasing involvement, you have more points, except with the exception of patients who have complete injuries who only get 2 points, as the likelihood of recovering neurologic function in these patients is very low. And most prominently featured in this scoring system is the status of the posterior ligamentous complex. And if it's intact, you have 0 points. If it's injured, you get 3 points. And if there's a suspected injury or even just a suspicion of an injury, there are 2 points awarded to that fracture. And basically, when you add up your points, if you have less than 4, then that patient can be safely considered for non-operative treatment. 4 points is sort of dealer's choice, and greater than 4 points is considered a fracture that would do best with operative management. And so some of the critiques of this classification system are really just the value that it places, or maybe not critiques, but the importance of the system is that the value that it places on that posterior ligamentous complex, even if there's only an indeterminate or suspected injury, because that can very quickly, particularly with burst fractures that are often stable or deemed stable, you can very quickly move them into an operative category with that suspicion. So there have been some studies to try to validate this classification system. I didn't include anything about this, but it does have high inter and intra-observer reliability, more so than other previous, like the Magrill classification system, certainly. But this was one study where they had 65 patients who were treated according to their TLEX score, so 3 or less got non-operative treatment. But in this study, they did an operation for patients who had 4 or more points on the TLEX score. Basically, their outcomes were that they didn't, in the patients who did not get a surgery, they did not have any adverse outcomes, and they did not have any decline in their neurologic status. And only 2 of those patients who were initially treated non-operatively eventually went on to surgery, and this was for continued pain and inability to mobilize without any significant improvement with conservative management. So this study essentially was saying that this seems like a safe classification system, particularly in the patients that it deems are safe for non-operative management. This was just another similar study, only 6-month follow-up, maybe not the best data, but they interestingly looked at all their patients who had a TLEX score of 4, and they did a retrospective review of comparing the patients who were treated non-operatively and the patients who were treated operatively. So they had 47 patients with 6-month follow-up. And as you might expect, they found no difference in their radiographic or clinical outcomes in these patients who had either surgery or no surgery, sort of further verifying that score of 4 as being the transition point between when operative management versus non-operative management is sort of equivalent. So another classification system that we very commonly use at our institution, and it makes communication about these injuries more straightforward, is the AO classification, which really divides thoracolumbar spine injuries into 3 types. A-type fractures involve the anterior column, B-type fractures involve both columns, and C-type injuries are translational or dislocation type injuries. And then within these types, there are basically different levels of severity. So A0 fractures are TP fractures or spinous process fractures that are essentially non-structural and basically unimportant. A1 fractures are wedge-type compression fractures. A2 fractures are more, I would almost call this a burst fracture, but for the classification, it's a wedge compression with a coronal split. And there's some evidence that these have higher rates of non-union. An A3 fracture is an incomplete burst, meaning superior or one end plate involvement, and a complete burst wouldn't have involvement of both end plates. And in terms of B-type fractures, these are considered distraction injuries involving both columns. You can have an injury that goes through the pedicle and is a completely osseous injury. or also known as a chance fracture. You can have anterior column injury with posterior column ligamentous injury, and you can also have hyperextension injuries. And once we get into B-type fractures, this is where we get into more consistently unstable injuries. Really, B2 and B3 are always considered unstable injuries. B1 fractures can occasionally be treated non-operatively, and we'll get into that a little bit later. And then C-type fractures, or any fracture with a dislocation, is the easiest way to think about it, and obviously unstable. So we'll get into management. We'll try to spend most of the time on some of the more controversial areas of management. So very briefly, transverse process fractures. We do see these a lot, and we do get called about them a lot. This is just an article in response to that I found. This was a patient study looking at a level 1 trauma center from 2002 to 2005 that included 300 patients who had transverse process fractures. And on average, most patients had actually more than one transverse process fracture. And while they were being worked up, they were held on log roll precautions and kept in bed. And what they found was when they consulted spine, often they either had no recommendations or they recommended bracing for comfort. And really didn't get much more out of us. But the truth is, the transverse process fractures are structurally, they don't import any structural stability to the spine. They are obviously points of insertion for the paraspinal muscles. However, fractures in them will heal. They are painful, and they can initially prevent people's mobility. However, they can be very reliably treated with conservative management, including NSAIDs, bracing for comfort, heat, ice, physical therapy, those sorts of things. One key thing to note really for the trauma teams is that transverse process, they can have a high association with abdominal injury or other injuries. And so they can be assigned to make sure that you're looking at your CT, chest, abdomen, pelvis to make sure there's no other either spinal injuries or other abdominal injuries. But the fractures on their own are really inconsequential, other than causing some pain for the patient, which will get better. The next type of fracture we'll talk about are compression fractures. These are really anterior column injuries, often due to a flexion and compression moment. Sorry, get a little lag here. And they generally occur in low energy elderly populations or elderly populations with low energy mechanisms. However, they can also occur in younger patients with higher energy mechanisms. And really, these are stable injuries. They're anterior column only injuries by themselves, and they do not necessarily require any further stability from a spine surgery standpoint. However, there are some, and these numbers can change depending on the study you read, but really, if you see greater than 50% compression, or if you're noticing a lot of kyphosis at the level of the compression fracture, neither of those two numbers in themselves convey instability, but they do sort of lead you to look closer at that posterior ligamentous complex, because if you're getting that much compression or that much kyphosis, there's a greater chance that there has been a disruption of that posterior ligamentous complex. So anytime you see that increased compression or increased kyphosis, it's important to really look at the posterior facet to make sure there's no gapping at that inner spinous process distance, to make sure there's no increased distance there. And if there is an MRI, you could look closely for signal intensity on the STIR imaging. But really, compression fractures are not something that we treat surgically in the sense of decompression or screws and rods or fusion. However, one thing that we can do, and is often done around the country, are vertebroplasty or cement or kyphoplasty or any cement augmentation technique to help give some stability to the vertebral body that's been compressed and for pain relief. And there's also been some evidence that these cement augmentation procedures may provide a survival benefit to these patients. The truth is that the vertebral compression fractures, especially in the elderly osteoporotic population, they're sort of like the fractures or hip fractures, in that they in themselves are not dangerous. However, they reflect a poor health of the host in general, and they're associated with high mortality rates overall, just because, as I mentioned, they reflect that overall poor health and overall poor bone quality in the patient. So if you actually look, this is a Medicare database study, so it is limited by the data that's collected in it. But they looked at 3-year survival rates for patients who had compression fractures, and they found relatively high mortality rates, really. But they also found that patients who underwent vertebroplasty or kyphoplasty had increased survival rates compared to those who were treated non-operatively, presumably because these cement augmentation procedures gave some pain relief for the patients and allowed them to mobilize sooner, presumably preventing complications of being stuck in bed, like stasis ulcers and pneumonia and those sorts of things. So there's been a lot of controversy about cement augmentation, vertebroplasty or kyphoplasty, either technique for compression fractures, and there's been articles sort of on both sides of the spectrum. However, this was a more recent meta-analysis done by Paul Anderson, looking at some really 6 studies, 7 studies that looked at both pain outcome scores and quality of life scores for patients who underwent cement augmentation for compression fractures. And he found that all the studies, when you look at them as a whole, there was a significant benefit for pain and health-related quality of life scores. Particularly with the pain, though, even though this benefit's significant, I mean, these numbers are the actual VAS changes, and it's not clear that that change is really greater than the minimally clinically important difference. But there is at least a significant change. And really the indication for the vertebroplasty and kyphoplasty is this top one, at least in terms of this talk, which is that anyone with a compression fracture, vertebroplasty and kyphoplasty generally are not used in the acute setting in the hospital, but for patients who are having difficulty mobilizing and they don't have any improvement in their pain within 2 to 3 weeks of their initial non-surgical care, these may be the best patients to be indicated for cement augmentation to help them improve their pain and get them mobilizing sooner than later to prevent other complications. So next we'll get into burst fractures. These are really probably where a lot of the controversy lies in terms of surgical versus non-surgical management of thoracolumbar spine injuries. There is a wide range of severity burst fractures on imaging, at least. This might be considered a more mild burst fracture here, where you have very minimal height loss and minimal encroachment of that posterior vertebral wall into the canal, whereas a fracture like this appears more severe initially. There's more collapse. There's more encroachment of that posterior wall of the canal. But the thing to keep in mind is, especially when thinking about the posterior retropulsion of the posterior wall, even though there's minimal canal space, there's evidence of patients who have 90% of their canal obliterated by bone who still are neurologically intact. And so you can't use CT axial cut to say, oh, this fracture needs to be decompressed because there's greater than 50% of the canal compromised. And we'll get into that in a minute. And it's really the patient's neurologic symptoms that determine if someone needs to be decompressed from that standpoint. But to back up a little bit, so what are the indications of surgery for burst fractures? As I mentioned, anyone with a neurologic injury, weakness, numbness, tingling, in a distribution that fits with where that burst fracture is, would be considered for a decompression and likely a fusion at the same time. And then beyond that, it becomes somewhat controversial who requires surgery for a burst fracture. A lot of these fit into that TLEX score of 4. A lot of them are neurologically intact. And it becomes a question of should they get further stabilization or not? And then on top of that, should that stabilization be done anteriorly or posteriorly? And we'll get into some of that literature in a minute. One other indication that I should mention now is the patients with intractable pain. We do see a fair amount of patients who come in with more severe looking burst fractures on imaging that can certainly be treated non-operatively. However, initially in their hospital course, they have a lot of difficulty mobilizing, and they end up being stuck in bed because of that pain and difficulty mobilizing, leading them to be at risk, presumably, for other issues like blood clots, stasis ulcers, pneumonia, those sorts of things. And so in those patients, we will consider an operation just to get them mobilizing sooner. So this was a study by Wood et al. This is actually a prospective randomized study with really long-term follow-up at 16 and 22 years. And what they were looking at were thoracolumbar burst fractures without neurologic deficits. And presumably these were all fractures without posterior ligamentous complex injury. So, and what they found when they looked at their long-term follow-up, so outcomes at 20 years, was that really there is no benefit to an operative procedure in terms of the pain scores. The non-operative patients were actually doing better. And in terms of the outcomes, at least in this study, they found that the non-operative patients were actually doing better in terms of their health-related quality of life scores. And this has been sort of backed up by other studies. This was a meta-analysis, including 4 trials, including the one I just mentioned. And again, they found that in patients treated for thoracolumbar burst fractures without neurologic deficits, when comparing operative versus non-operative treatment, pain, disability, and return to work were all equivalent in their long-term follow-up. And so once again, that kind of gets back to that score of 4, and that's sort of the reason why it is, operative versus non-operative could be considered, although, these studies would lead you to believe that non-operative is probably the best course of action for most of these thoracolumbar burst fractures. So this was another study kind of getting into the granularity of non-operative treatment. And this looked at 96 patients who had burst fractures who were neurologically intact in between T11 and L3 with kyphosis less than 35 degrees. And these patients were either treated with a TLSO brace that was worn for 10 weeks or no brace. And again, they found no difference in their outcome measures, including disability pain score, satisfaction scores, and kyphosis. So even if you're treating non-operatively, a brace, there's not great evidence to suggest that a brace will be helpful in maintaining any sort of alignment or improving their healing. The brace may help the patients mobilize initially, which may be worthwhile, at least initially. However, I have not seen any good evidence to support or refute brace wear in these patients. So one other consideration, if we have a burst fracture that maybe it's unstable or maybe there is a neurologic deficit, and we're considering an operation, the next question is which approach is superior, an anterior or posterior approach? The anterior approach, particularly once you get above, L1 and above, well, really that's when you would use it, but an anterior approach does give you a direct view of the bone that is encroaching from the posterior vertebral wall. and does allow for a direct decompression of bone in patients who have neurologic injury. And it does theoretically give you an improved ability to recreate your anterior column support, and theoretically give you a better maintenance of your kyphosis correction, especially for shorter fusion segments. Whereas posterior surgery is generally a shorter operative time, less blood loss, and fewer serious complications, although those complications certainly do occur at similar rates to anterior procedures. And when you look at some of the studies comparing anterior versus posterior, I will say that there's some conflicting evidence. I want to make sure I don't skip anything here. But in general, the anterior versus posterior, the outcomes tend to be almost equivalent. So this was a prospective randomized study, again, by Wood et al. And they had 38 patients who completed a minimum of 2 years of follow-up. And what they found in their study was that patients had no differences in pain, disability, or return to work at 2 years. And interestingly, they also had almost the exact same average amount of kyphosis following their surgery, whether they're fixed with an anterior cage or posterior only fixation. And most people returned, despite the surgical approach, most people their kyphosis returned to their basically their preoperative level at their final follow-up. So this was another study. There was a meta-analysis that again included that previous study, but looked at 4 different randomized clinical trials, and 3 controlled clinical trials. And again, they found no difference in Cobb angle or kyphosis. They found no difference in return to work. And interestingly, they also found no difference in neurologic recovery in patients treated with an anterior versus posterior approach. So even though that anterior approach does allow us that direct decompression, in this study at least, these studies at least, they did not find any difference in neurologic recovery rates between patients who went anterior or posterior, underwent anterior posterior procedures. And the conclusion of this study was that the anterior approach had a higher cost, a longer OR time, and increased blood loss, although transfusion rates were similar. And so they recommended really against an anterior approach because they didn't see a benefit for those costs. So we'll move away from burst fractures and get into the more severe injuries, and we'll kind of breeze through these because the treatment management is relatively straightforward. So flexion distraction injuries are injuries where you have an anterior column that fails in compression and a posterior column that fails in tension. And these are unstable injuries. So these are those B-type injuries where you have injuries to both columns, and these are almost universally considered unstable. This is another example of a fracture that may on first look not look so severe, but if you look closely, you'll see these fractures in the spinous processes indicating failures of both the anterior and the posterior column. And then you can also see on this MRI of this patient the increased signal on the stir at those fracture sites of the spinous processes extending into the interspinous ligaments. So management of these B-type injuries, particularly the B1 and B2 injuries or flexion distraction injuries, is rarely non-surgical and almost always surgical. I mentioned this briefly before, but in the case of maybe low mobility patients who are maybe sicker and have transosseous fractures or B1 type fractures, you may be able to consider non-operative treatment there for some of those injuries, but really for the most part, these are all considered surgical due to the stability of the pattern. Fracture dislocations, obviously these are unstable injuries as there's been a dislocation. In general, These are very commonly associated with neurologic injury, probably most commonly with complete injury. And the surgery for these is not so much for the complete neurologic injury, but to give the patient stability so that they can be moved safely in bed by the nursing staff to prevent bed sores and allow them to be moved for whatever procedures they need, and also so that they can mobilize sooner, get to the chair sooner, and begin the recovery from their other injuries earlier, and hopefully prevent long-term mortality. But again, these are almost always considered surgical injuries to give stability to allow for mobilization of the patient. Last fracture type we'll talk about are the B3 injuries, or the hyperextension injuries. And this will kind of lead us to a very short discussion about DISH and AS, or ankylosing spondylitis, as these hyperextension injuries are most commonly occur in patients with those diseases. So these are just two examples of patients with hyperextension injuries. You can see both patients have relatively mild, but some DISH or just anterior fusion in their thoracic spine associated with some kyphosis. And you can see these bridging osteophytes between the vertebral bodies here. And then you see this extension injury through the disc space, which is really the weakest part of this anterior tension band. And as I mentioned, these tend to occur in patients who have DISH or ankylosing spondylitis. And the reason for that is those patients tend to fuse, and they tend to fuse in a kyphotic position, and any force directed posteriorly or extension force is more likely to cause an injury in this almost a long bone of their spine. And these are really considered unstable injuries. This is just another more severe hyperextension injury. There's actually two hyperextension injuries. And this also illustrates this theory that the sternum is also part of your support of your spine. And when you have severe extension injuries, you can also have fracturing of your sternum as well. And this may give you another layer of the severity of the injury. So again, these hyperextension injuries are almost always considered unstable, and almost all of them undergo surgical fixation, generally a posterior fixation with screws and rods. Just a quick note on DISH and ankylosing spondylitis. This patient on the left is a sort of classic image of DISH with these flowing wax type anterior osteophytes, whereas ankylosing spondylitis is more of this bamboo spine with ossification of the discs. But both of these cause a fused spine and generally cause a fused spine in kyphosis. And the importance of recognizing those two things is that these patients are really very different than your normal fracture patient. So patients who have ankylosing spondylitis in general, or really any ankylosed spine, have 4 times more spine fractures than the general population. And they have a very high incidence of epidural hematomas and neurologic injury at the time of their fracture. One of the most difficult things for clinicians in these patients is that fractures can be very difficult to diagnose initially. The patients often present just with pain and a story of a very low energy or maybe even no mechanism of injury. And because of this, the fractures are often missed 40 to 60% of the time on X-ray alone. And so really anyone who has ankylosing spondylitis and back pain, they should be getting full spine imaging, including X-ray, CT, and maybe even MRI as well. And up to 15% of these patients will actually present with a secondary decline in neurologic status sometime after their initial injury. The mortality rates are particularly high in these patients, and they can be up to 80% mortality rate of up to 80% in patients over 80. And there's overall high complication rates regardless of your treatment in both patients with ankylosing spondylitis and with DISH. And really the treatment for anyone with a fracture where they have an ankylosed spine, the treatment is the fusion with a long posterior directed construct, because that'll give you the ability to create a longer, more extensile construct to give this the most support. And last, I'll leave it on this slide because I think this may generate some more discussion, or at least start the discussion. But the last thing to consider when considering operative fixation for these thoracolumbar injuries is whether an open approach or a percutaneous approach could be employed. Some of the factors to consider for minimally invasive or a percutaneous approch are that generally this is a faster procedure, which can get the patient off the table quicker, and it's beneficial for sick or unstable patients. Percutaneous approach generally involves a secondary surgery for removal of the hardware, because really it's not a fusion surgery. This is really more of an internal brace to hold everything in place while the bone heals. But then the idea would be to remove the hardware so that once the fracture heals, you can allow potentially for motion preservation in younger patients once the hardware is out. And then open-based procedures, really these are the gold standard. These are going to be a fusion procedure. It's going to be a one-time procedure. The surgery is longer, questionably more blood loss. And really the advantage of the open procedures is not dependent on being able to get good imaging, whether that's due to a deformity or body habitus. And you can find your start points more easily in an open approach. And it also allows for direct reduction if there's any sort of dislocation or facet perching or anything like that. So I'll leave kind of the last 15 minutes for any discussion if anyone has any points. But thank you very much, and happy to answer any questions.
Pete, that was great. A really nice, solid overview of the whole subject, and I think you hit most of the high points, and I think you put the appropriate emphasis on the things that are important. I don't know, how do I share my screen?
I might be able to unshare mine. Let me see.
Yeah, can I just share my screen for a second? I don't know, how do I do that?
I'm going to unshare mine, and then you might, there's a button in the top right.
Man. Go to the top and request control.
Where is that?
There's a button that it's a rectangle with an arrow on it. Arrow point.
The leave button.
I gotta allow Teams to have my thing. I don't know if I'm going to be able to do this.
The share content.
Yeah, I'm gonna have to quit and reopen. I'm gonna drop off for 2 seconds and come right back. I want to show you guys a video that I think is interesting in context, but I gotta quit and come back. I'll be right back.
So Pete, excellent job. Also, I agree. This is a ridiculously huge topic, as you know, right? And
every other day for us. There's more questions that come up every other day.
Right, and it's hard to get through. Most of the literature that is there is not very good, as you know. And does not necessarily help drive your decision making every day. But a couple of things that I think are interesting with regards to neurology status, and you touched on this a little bit about anterior decompression. I think it's important to understand that there's data to suggest in incomplete patients that it really doesn't matter whether or not, there's some studies suggest you just need to stabilize those patients and leave them without a decompression. You can decompress them through the back. You can decompress them through the front. And really, at the end of the day, the neurologic outcomes are very similar, which is amazing to me, right?
Right, and that was one of the meta-analysis I showed, and I didn't really get into the details, but that's exactly what they said. Was
right, and the fact
the approach really didn't affect the outcomes.
Right, or even decompressing patients. There's data from OUS outside the United States to suggest that in the face of an objective neurologic deficit, in the face of objective neurologic compromise, that stabilization alone allows for neurologic improvement, right? And we know that canal remodeling occurs, and patients talk to you where they're like, oh my God, I have all this bone in my canal. Oh my God, I need to get it out. It takes about 18 to 24 months in the best of circumstances to get the macrophages in your, an osteoclast in your bony canal to eat away at those bony elements.
Right, and
So,
even then you only get about 50% resorption, I think.
Right,
Max.
exactly. But clinically, how many patients have we operated on for post-traumatic stenosis this year?
Zero.
Exactly. And if anybody's going to see it, we're going to see it more than anybody else, right? So I guess my point is, in America, if you come into our hospital, you have an objective neurologic problem, you have objective evidence of neurologic compromise, you're going to get decompressed, right? Because we believe it may actually hasten neurologic recovery. It's irrelevant whether or not you go front, back, etc., extracavitary laminectomy, whatever. But the fact that you need to do a decompression is there. There is some weak evidence to suggest you didn't bring up a sort of a historic paper, the Gertzbein paper, that has some evidence to suggest that if you do them from the front, they have better return of visceral function, so bowel bladder return. There's some weak evidence to suggest that that is true, but my recollection, maybe Gel remembers this when he gets back on or somebody else does.
I'm here.
Is I think that was a very small, it may have been like 15 or 16 patients, 17 maybe. That's my recollection.
Yeah, the problem that was the SRS. They looked at the SRS database, and it's like thousands of patients, but only 5 of whom, had anterior procedures. Like it was like a complete extrapolation of a very small portion of a data set that probably was not statistically valid. But when it was published in 1979, people were like, "Oh, look at that." Let me just. I think this cements in. If I can interrupt you for a second, Steve. If I can grab the screen now. I want to show you guys. Can you see my screen?
Yes.
Yeah,
Okay.
that's you doing your little gymnastics.
So this is a video from Austria in the 1930s of aviators who were injured in plane crashes, right? So just watch this and you'll see really what the outcome of truly non-operative management is.
Accident June 13th, 1934. Complete paraplegia L1. Accident April 28th, 1934. Plaster cast removed September 15th. 12 thoracic and 1st lumbar vertebra. Accident June 8th, 1934. Plaster removed September 2nd lumbar and 4th lumbar vertebra.
So,
all right, I don't need to see any of this pornographic stuff.
So
okay, Dr. Mengele.
The point is that, we look at these, we search, we try so hard to look at the MRI scan to maybe there's PLC injury, maybe, and oh God, we must fix that. And in, young, healthy people who are appropriately nursed and have decent bone healing qualities, non-operative management really can lead to really some excellent results. So, I think just goes to prove that, read a lot of the studies on operative versus non-operative treatment of burst fractures. And as Steve has made this point, and I don't know if he did when I was off the call, but if you look at the inclusion criteria for those studies, and it says, well, we can't prove that surgical treatment is better than non-surgical treatment, the vast majority of those fractures we would never treat surgically here anyway. Like, you know,
Right.
like, I mean, people, there's many people are very, what I would consider aggressive in treating fractures that don't necessarily need surgical treatment.
Right. I agree.
Dan, this is Kavanaugh. Do you think, you know, like I put on a couple Risser casts in my time, you know, and they're pretty complex to do. Do you think the casting actually made a difference in these patients?
I think with a well-fitted, well, I think I have about 5 of these videos, and I'm not going to show them all. Denny Kwok gave them to me at a meeting one time, and they put these people on Risser tables, and you're right, they did hyperextension casting, and you know, they were masters of the non-operative management. I don't know that, you know, we know that really made the difference versus the fact that they just were the natural history of these fractures. I mean, there's a huge history of non-operative fracture treatment in England where they just kept people in bed for a while and let things get sticky and got them up in a brace, right? So I'm not sure it's the cast. I think and you know, when you're talking about Mrs. Jones, who weighs 400 pounds and is osteoporotic.
That's exactly what I'm talking about.
Right, but
like you said, you can't brace Jello. You told me that.
But if you notice, these guys were all skinny, young, healthy, and you can see, you got to see these videos. The fellows want them. I'm happy to share them. But in their plaster casts, these guys are doing the same gymnastics that they do after they take the cast off. I mean, they rehabbed them unbelievably aggressively from our perspective, and I think that goes a long way to getting people good results.
Hey, Pete, it's Eugene. Great talk. Dr. Gelb, do you know how long they put those guys in the cast before mobilizing them? Or
well, I don't know. Of course, I mean, this is a video from 1935, and although I'm old, I'm not that old. You know, I think, but they only wore the cast. I mean, if you listen to the video, those casts were on for 3 or 4 months. It wasn't like they were a year. So if our studies are bracing people for 10 weeks, it's not that much longer. And I'm not saying trust me, I'm not saying don't operate on folks. I'm just saying that you can do a lot of non-operative management in many fractures. And I think sometimes we worry more than we need to about well, God, if we don't fix this, something catastrophic is going to happen. Because that's really pretty rare.
I love how they drew the injury on the cast.
Yeah, well, I think that goes to show, right? Because most people would say, he probably had a little burst fracture, like compression injury. These were true fracture dislocations.
Yep. Crazy. All right. Any other comments? Pete, great job.
Thanks.
It's interesting. It's something you guys really don't see that much of, so.
Pete, the only other comment that I have is that Medicare database study is the only one, you know, that I found that supports kyphoplasty or vertebroplasty.
Yeah.
And that's kind of the rationale why I do it, and I'm pretty conservative about. I only do it on patients that can't get out of bed. Basically, I try and mobilize them with PTOT, and if they can't get up and they can't wear a brace and they're still in bed, I'm concerned about them getting a pneumonia or a DVT or something. So I do it, and that's the reason why. So I'm curious if anybody has any thoughts why kyphoplasty might be better than vertebroplasty in that study. I'm just curious, but I don't know.
Well, I think in general, there were some studies that showed, at least initially, that there was, fewer complications with the kyphoplasty, presumably because there's more space for the cement. But I couldn't speak to that study. I'm not sure why it would have been.
Yeah, I think if you look at the meta-analysis data between kyphoplasty and vertebroplasty, I think there's not really a great deal of difference. The longevity data that you described from the Medicare that Skolasky's group had done, he's like the king of meta-analyses, you know, and he's right here in our backyard. He really knows how to do a nice meta-analysis. But the problem with these huge database studies, and I think you alluded to this before, is that when you actually go through the database studies, there's so much missing data. They just don't have all the points. Even death, right? Mortality, which is what they were looking at. You know, you would seem to be a very easy endpoint to determine, but they just don't have all the data. Most of the data is incomplete, especially in the Medicare database analyses and the ACS, the American College of Surgeon database studies. Notoriously, they're missing, you know, anywhere between 30 to 70% of the data, depending upon what you're looking at. So that might be why, Dan. It's just bad data.
It may also just be a selection bias for a lot of those patients too.
Well, great. Well, thanks, Pete.
All right, thanks everyone. Have a great day.
Thanks,
Great
Pete.
job.
Everybody have a good day.
Bye-bye.